7, 6, 5, 4, 3. Good morning from Miami Beach, home of Neurosurgical TV. We have the pleasure and the honor of hosting another webcast for the Bangladesh Pediatric Neurosurgery group, Grand Rounds. And I'd like to introduce the head of that group, Sudipto Mukherjee, who I met online. And he did a series of 6 webcasts, and this is the 6th of those 6. Welcome, Sudipto.
And now I invite Dr. Arman for presenting a very big topic, that is posterior fossa tumor in pediatrics, its different approaches and management. Dr. Arman, please.
Can you hear me?
Yes.
Yes.
Please share your screen.
I'm sharing my screen. Can you see my screen?
Please
Yes.
make it full.
Can I start?
Yes, yes.
Perfect.
Welcome to session 6 of Paediatric Neurosurgery webinar series from Bangladesh. It is organized by John Bennett of Neurosurgical TV and Sudipto Mukherjee, Associate Professor and Head of the Department, National Institute of Neurosciences, Dhaka, Bangladesh. My heartfelt thanks to John Bennett and Dr. Mukherjee. I am Dr. Arman, Associate Professor, going to present my topic on posterior fossa tumor in children. This is National Institute of Neurosciences hospital situated at Dhaka, capital of Bangladesh, where more than 45 neurosurgeons work here and performed near 3,000 operations in last year. In Department of Paediatric Neurosurgery, we did neurosurgery 538 in the last year. Regarding posterior fossa surgery from 2014 to till now, we did 261 posterior fossa surgery. Study of outcome of posterior fossa surgery is in progress. We got 119 patients with posterior fossa surgery from 2020 to till now. Age range is 1 year to 16 years. Mid age is 8.6 years. 60% are male and 40% are female. Most common clinical manifestations are headache, vomiting, visual impairment, tendency to fall or walking difficulty. Papilledema found in most the cases. Regarding extent of tumor resection, we did gross total resection in 55% of patients and near total resection 34% and only 4% subtotal resection done. Histopathology revealed 32% cases are medulloblastoma, 36% are pilocytic astrocytoma, 24% are ependymoma, and others are ATRT, schwannoma, meningioma, and cavernous hemangioma. 74% of the patients are associated with hydrocephalus, need CSF diversion. 53% of the patients we did BP shunt, and 21% of the patients we did ETV. Now, introduction. The posterior fossa is the area of the brain that extends from tentorium to the foramen magnum and contains the most complicated brain structure that regulate vital functions. The most pediatric brain tumor are infertentorial, that are 60%, The most common posterior fossa tumor in pediatrics include medulloblastoma, cerebellar parasitic astrocytoma, ependymoma, and midline brainstem diffuse glioma and atypical teratoid rhabdoid tumor. Clinical manifestations related to hydrocephalus secondary to obstruction of the fourth ventricle. Many of these tumors escape diagnosis until they are very large in size due to elasticity of the skull, the adaptability of the developing nervous system to compensate for deficit. The most common presenting manifestations are due to raised ICP. These are headache, vomiting, visual impairment, and some manifestations due to cerebellar dysfunction, that means truncal ataxia, appendicular ataxia, when compression of the brainstem causes long-term sign, and others are arrest or regression of psychomotor development, macrocrania, poor feeding, and few cases we find seizure also. Pilocytic astrocytoma of the cerebellum is the common posterior fossa tumor in children. 10% of the pediatric brain tumors, 27 to 40% of pediatric posterior fossa tumor, usually present during second decade of life, mean age between 6 to 8 years. No sex predominance. Often cystic, and half of these have mural nodule. On emails, non-enhancing cyst with enhancing mural nodule. And recent 2021 WHO classification, it is considered as circumscribed astrophatic glioma. Surgery is the mainstay of treatment, and maximal safe resection is the target. No radiation in post-op in case of hospital resection, should be followed with serial MRI. Recurrence is common, need reoperation. Radiotherapy is indicated for non-resectable recurrences. Chemotherapy is younger in case of 3 years of age, less than 3 years of age. When associated with hydrocephalus, some surgeons prefer bipition prior to definitive surgery, and some prefer EBD at the time of surgery. In our department, we usually prefer bipition prior to definitive surgery. Ependymoma is another most common tumor in pediatrics, posterior fossa. It is benign tumor. 9% of pediatric brain tumors, 60 to 70% are infertentorial, arise from the floor of the fourth ventricle. There are two subgroups of ependymoma in posterior fossa. Posterior fossa ependymoma group A, median age at onset 3 years, male preponderance, median survival is 65%, paramedian lateral location is present, worse prognosis in younger patients in case of less than 24 months. In posterior fossa ependymoma group B, late presentation is common, median is at onset 25 years. It is uncommon in pediatrics, male preponderance, median survival between 80% and 90%, and it is located in midline. Surgery is the mainstay of treatment. Maximal safe resection followed by craniospinal axis radiation. Medulloblastoma is the most common pediatric brain malignancy, WHO grade 4 embryonal neuroepithelial tumor, arise in Burmese. Medulloblastoma is approximately 20% of all childhood brain tumor and 63% of intracranial embryonal tumors. Medulloblastoma most commonly about 70% occur in children under 10 years of age, approximately 1.7 times more common in males than females. On imaging, medulloblastoma tend to protrude into the fourth ventricle from posterior aspect of the roof, whereas ependymoma usually arises from the floor. When metastasis is present, there is poor prognosis. Clinical outcome of neuroblastoma strongly depends on patient's age, histopathological features of tumor, as well as the genetic profile. Standard risk patients are when patient's age is more than 3 years, having gross total resection and not metastatic. High-risk patients are less than 3 years of age, having subtotal resection and metastatic disease. There are 4 histological types: classic, desmoplastic, or nodular, extensive nodularity, large cell or anaplastic. 4 genetic or molecular typing. Genetic and molecular typing have significant prognostic value and predict survival. Each molecular subgroup shows different methylation and gene transcription profile, epidemiology, clinical presentation. Each medulloblastoma subgroup exhibits distinct recurrence pattern and prognosis and response to chemotherapy and radiotherapy. GAB1, beta-catenin, and filamin A and EF1 are the 4 antibodies are used to distinguish WNT and SH from non-WNT and non-SH subgroup. And these are the antibodies for each subtype of genetic or molecular of medulloblastoma. However, such diagnosis by immunohistochemistry remains limited without genetic analysis. In session 4, Dr. Sudipto Kumar Mukherjee narrated nicely molecular or genetic subtyping of medulloblastoma. It is available in YouTube. I think you are beneficial to see this video. WNT activated type occur in 10% of the patients, maybe very favorable prognosis. It occur between 3 to 7 years, and activation of WNT pathway, mutation in beta-catenin gene, and there is accumulation of nuclear beta-catenin. There is also chromosome 6 monosomy present, and histological types are classic or giant cell. Type 2, sonic hedgehog activated group occur in 30% of the patients, mainly occur in infants and adults. When occur in infants, it is arise from Burmese, and in older children, arise from cerebellar hemisphere. Favorable prognosis in case of children, good, others intermediate. There is activation in SHH pathway. There are 2 subtypes, TP53 wild and mutant. In wild type, this is favorable prognosis. There is MYCN amplification, and histological types are desmoplastic, nodular, or extensive nodularity. In non-WNT and non-SHH group, they are classic giant cell in histology, occurring up to 70 years, male predominance than female. In group 3, occur in 20% cases, usually affects infants and children. It has poor prognosis and it has MYC amplification. In group 4, occur in 40% patients, peak incidence between 5 to 15 years. It has intermediate prognosis. It has MYCN amplification. This is a rare presence in posterior fossa, that is ATRT, atypical teratoid rhabdoid tumor. In 2021 WHO classification, it is classified as other embryonal tumor. It is highly vascular, mostly affects children under 2 years of age. Median survival is less than 12 months. In posterior fossa tumor, surgery is the mainstay of treatment. The goal of surgical resection is the gross total resection, if not possible, maximal safe resection. In case of brainstem invasion that limits complete surgical excision, better to leave a small residual on the brainstem. Radiotherapy has the role to treat posterior fossa tumor surgery before sent to oncologist. We usually screen whole spine, and in metastatic cases, we see metastatic whitish coating resembles icing sugar, arachnoid thickening sugar coating. And radiotherapy is indicated with craniospinal axis. Children older than 3 years should be initiated before 28 days postoperative. Chemotherapy can be used to delay the need for radiotherapy in children below 3 years of age. If younger age group, less than 3 years, have metastases, have residual more than 1.15 square centimeter, poor Karnofsky performance is called poor prognosis. In posterior fossa surgery, we usually did suboccipital craniotomy or cranectomy. C1 posterior is removed if needed. Patient is positioned prone with head on machine head holder or horseshoe headrest. Thorax is elevated 20 degrees. Neck is flexed to leave room to insert two fingers between the chin and chest. To prevent venous congestion, shoulders are retracted inferiorly with adhesive tape. Midline incision is made 1 centimeter above from inion to C2 spinous process. Subperiosteal dissection is made. Suboccipital craniotomy is performed. Dura is opened in a Y pattern. In our practice, you see that is upper dural incision, both upper limbs of the Y. We usually this incision to make it U instead of V to better closure. Please remember, we usually practice this incision to make U instead of V to better closure. Two main approaches to the fourth ventricles. One is transvermen approach, that is splitting of the cerebellar vermis in the midline. This is vermis. Inferior vermis is incised and two halves are retracted. This is transvermen approach. This is common approach, have some complications. And other approach is talovelar approach through cerebellomedullary fissure. Through cerebellomedullary fissure, this is tonsil, this is tonsil, this is cervical cord, and this is vermis. Talovelar approach is through cerebellomedullary fissure between talacordia and inferior medullary bellum. You see, talacordia and inferior medullary bellum is opened to enter the fourth ventricle. Pros of the transvermen approach is wider and slightly more rostral exposure than talovelar approach, and cons of the transvermen approach are risk of caudal vermis syndrome, that are truncal ataxia, disequilibrium, nystagmus, and cerebellar mutism. And pros of tabular approach: to reduce the risk of cerebral dysfunction, improve access to the lateral recess of the foot ventricle, and cons are it has narrower corridor and limited access to deep and large tumor involving the rostral third of the foot ventricle. Now I show few cases of my operating case. I share with you 8 years old girl presented with headache, vomiting, blurring of vision, difficulty in walking. Fundoscopy showed papilledema, and MRI of the brain showed there is a large posterior tumor, mainly occupying the left cerebellum. You see, lesion compresses the foot ventricle and pushes towards the right side, and solid part enhances more with contrast. And we did suboccipital craniotomy, left cerebellar transcortical approach. This is video. This is left cerebellum. We enters into the tumor through transcortical approach. You see, cystic portion of the tumor came out and sucked out. We tried to dissect solid part from the cerebellum. We removed tumor by piecemeal. After removal of the tumor, hemostasis was achieved. And after surgery, patient recovered well. And first POD, we did post-op CT scan of the brain. There is gross pleural resection was done, and histopathology revealed pilocytic astrocytoma. And on the day of discharge, she is okay, and in follow-up period, she was nice. In another child, 9 years, 5 months old boy, presented with headache, vomiting, MRI showed large posterior fossa tumor, and you see there is much adherence with brainstem and heterogeneous enhancement, and we did suboccipital craniotomy in last year. You see the tumor is in between the tonsil, tumor is exposed. We cauterize the surface of the tumor. We dissect tumor from surrounding. tumor is much adherent to the cerebellum. We try to remove you see this is cerebral aqueduct and also pulsatile CSF is seen. Hemostasis was achieved after tumor removal. After operation, patient recovered well. In first POD, we did post-op CT scan of the brain. A small part of the tumor is left behind with brainstem. Near total resection was done. No hematoma is seen in postoperative tumor bed. Histopathology revealed medulloblastoma, and she got radiotherapy. And in follow-up period, she's okay, except mild ataxia is present. And in post-op MRI, follow-up post-op MRI, we found no residual and no recurrence. Another patient, 10 years boy, presented with headache, vomiting. MRI of the brain showed large posterior tumor occupied in the fourth ventricle. Heterogeneous contrast enhancement is seen. And we did suboccipital keratomy and gross total resection was done. Histopathology revealed medulloblastoma. We did it 7 years ago. Prior to definitive surgery, we did VP shunt in this patient, and she got radiotherapy. And in follow-up period, recently, she was nice. And follow-up MRI showed no recurrence still present. Another 4-year, 3 months old girl presented with vomiting, tendency to fall. Her fundoscopy showed papilledema, and her MRI of the brain showed lesion in the posterior fossa, fourth ventricle, and contrast enhancement is present. There is a large tumor, goes upside and seems to be adherent with fourth ventricular floor. And we did suboccipital keratomy through transvermian approach. You see arachnoid is cut to release CSF. This is spica on the left, on the right side. You see, this is tumor. This is tumor. Inferior bun is cauterized to enter the fourth ventricle. Tumor was removed in piecemeal fashion. You see the floor of the fourth ventricle, lower half of the fourth ventricle, you see the cerebral aqueduct, solid part of the tumor is adherent with floor. We try to very cautiously remove the tumor. You see how much adherence with fourth ventricular floor. So we decided some part of the tumor was left behind, and after hemostasis, post-op CT scan of the brain showed near total resection, but post-operative period was eventful. There was so many complications. She stayed few weeks in ICU, needed tracheostomy, and histopathology revealed appendectomy grade 2. After seeing so many complications in postoperative period, we review the case again and see there is large tumor, adherence with fourth ventricular floor, and we did through transvermian approach. And much adherence with fourth ventricular floor, and we have decided to avoid transvermian approach if possible and prefer tailobellar approach in subsequent cases. In another 2-year-old girl presented with vomiting, difficulty in walking, MRI showed large posterior fossa tumor, and you see tumor compresses much fourth ventricular floor, causes thinning of the fourth ventricular floor, and we did suboccipital keratomy through tailobellar approach. Arachnoid dissection to release CSF from cisterna magna. This is tonsil, and we try to open through cerebellomedullary fissure and open inferior medullary blunt and paracardia to enter into the fourth ventricle. You see this is spica in opposite side. Now you see the tumor is exposed through tailobellar approach. We remove tumor by piecemeal fashion. Much adherence with cerebellum. you see the floor of the fourth ventricle, lower half. Now you see the cerebral aqueduct. We removed clot through cerebral aqueduct. Hemostasis was achieved. We did near total resection. This is post-op CT scan. We did shunt prior to definitive surgery. And histopathology revealed medulloblastoma. On day of discharge, she was reasonably well. Another 7-year-old boy presented with headache, vomiting, difficulty in walking. Fundoscopy revealed much papilledema, and the CT scan showed large posterior tumor. MRI showed a solid part with cystic portion and much adherence with floor of the fourth ventricle. And we did near total resection 3 years ago. And this is the post-op CT scan. Some tumor was left behind. And histopathology revealed apenoma grade 2. Immunohistochemistry revealed anaplastic apenoma grade 3. This is day of discharge patient's picture. And he got radiotherapy, and in follow-up period, he's okay. And we did MRI in last year, no residual and no recurrence. We did near total, but in follow-up MRI, there is no residual and no recurrence. Okay. Another 10-year-old boy presented with headache, vomiting, blurring of vision. Frontal photograph showed papilledema, and CT scan showed large solid tumor in the posterior fossa. In last year, we did operation. Between the tonsil, tumor is found. We did it through transpermanent approach, and tumor was removed through piecemeal. You see cerebral aqueduct and hemostasis was achieved. And this is gostral resection was done. And this is post-op CT scan. And histopathology revealed medulloblastoma. Another 5-year-old girl presented with headache, vomiting, difficulty in walking, and blurring of vision. Frontal photograph showed much papilledema, and MRI of the brain showed large posterior tumor and some cystic portion also found. This picture on the day of operation just before induction. I witnessed this event. She prayed herself, "Oh God, please cure me. I have never seen before." I also prayed myself in my heart, "Oh God, please save this child." We did suboccipital cranectomy through transvermine approach, and God saved this child. In postoperative CT, a brain showed gross total resection, and histopathology revealed pilocytic astrocytoma. This picture of the day of discharge in 1 year after operation, in follow-up period, she is okay. What are the complications of posterior surgery?
Baba.
These are hematoma, edema, acute hydrocephalus, tonsillar herniation. In brainstem compression, these are the bradycardia, increased blood pressure, respiratory distress. Pseudomeningocele can occur. When pseudomeningocele occur, we try to tap and wrap and give acetozolamide. When recur, we assess the patient to develop hydrocephalus. When hydrocephalus is present, we usually did BP shunt, and not respond, we finally re-exploration may need. In CSF leak may occur. In case of CSF leak, we try to suture again. We give lumbar drain, and if not leak stop, we re-exploration may necessary. Infection may occur. Cerebellar mutism is not uncommon in posterior surgery. Ataxia and hypotonia may present. In conclusions, surgery with safe resection remains the mainstay of treatment. Surgical treatment, posterior fossa tumor represents significant challenge for neurosurgeons. Outcome of posterior fossa tumor surgery depends on preoperative status of the patient, nature of the tumor, and extent of the resection. Clinical outcome of medulloblastoma strongly depends on patient's age, histopathological features of the tumor, as well as genetic profile. In recent years, there have been great technological advances in molecular biology and neuroimaging. Despite surgical and technical advances, posterior fossa tumor surgery still remains a challenge. While the identification of the 4 genetic subtypes of medulloblastoma has helped categorize the patients and predict the prognosis of the disease, there is still much to be learned. With development of drugs targeting the aberrant pathway of each medulloblastoma subtype, there is hope that prognosis can improve for all patients with medulloblastoma. This is end of my talk. I am stopping here. Thank you very much, everyone.